everybody is in place. I welcome all the knowledge keepers of the medical in digitalization and in terms of HIMSS or HIMSS and what it is all about. We'll tell you at our conference. And the floor is given to Sergei Alexakhin, the director of Nikiforov Center. Good afternoon, dear colleagues. I hope that I wouldn't frighten you with my uniform. People are used to see me in a civilian suit or in medical overalls, but today we have such an intensive day. We have several meetings going on and video conferences, so I have to communicate with ministries in this attire. Allow me to welcome the long-awaited for conference and the delegates of the conference, highly esteemed presidium at our center. It is not by chance that it happened in such a way. We've been thinking for a long time about the information technologies in medicine, and Mikhail Yurievich probably is one of the first, my assistants, my deputies, who has become he was allocated to medical information technologies. We started working back in 1999, and at that time already we've been thinking about the implementation, but the implementation in reality took place or started to take place in 2003, 2004, and the platform which we are using now has been selected finally in 2006, I think, 2006. That was Mitrak 6, that's the platform, and we still are using it. We have quite an extensive experience, and you know the attention that is being paid now to digitalization of medicine. This is one of the federal healthcare programs dedicated to medicine digitalization. A lot is being said, but certainly it is better when more things are done than said. And I hope very much that the conference that is held at our center today will become a field for discussion, sharing the experience, including our experience, and that's why we are hosting this conference and letting you to get acquainted with our work. And probably the result of our work in this field, well-deserved result, is that we were the first ones out of the medical institutions in Eastern Europe have received HIMSS certificate, not just a certificate, but 6th level, while the maximum is 7 levels. And I'm really grateful for this evaluation of our work, and I would like to wish you all success in your professional growth, and so that information technologies would help you not only in your work, and I understand that mainly we have here representatives of IT from medical institutions, but I also wish you to help the doctors in a very difficult work of theirs when they provide care to their patients. We had the day of healthcare professionals yesterday, and this is a very difficult profession, so allow me to wish you success in your very generous work. Not simple, but very generous. And now, please, Alexander Martynov, General Director of Sparm company, for his welcoming words. Good afternoon, everybody. I'm really very glad to see you all here and grateful for the fact that you've accepted our invitation and joined our conference. This conference is a kind, it means a lot to us. And this conference would have been impossible without the participation of our partners. And among them are HIMSS, Intersystem Corporation, and our hosts of today, or the Nikiforov All-Russian Emergency and Radiation Medicine Center. Sergei Sergeyevich mentioned that we have cooperated for many years. We've cooperated with InterSystems for more than 20 years, and for 20 years with the Nikiforov Center. With HIMSS, not that many yet, but in the course of these years, we've managed to achieve a lot. Our joint work led, and it was a very interesting work, mind you, very useful for us from the professional point of view. It led to the fact that the Nikiforov Center really was certified by HIMSS level 6, while we, meanwhile, became certified consultants of HIMSS in Russia and CIS countries, which is not bad. And I'm sure that this area of our activities will be growing and developing, because when we pass over to mature information systems, it is always interesting how efficient they are and how they impact the quality of medical care provision. I'm very grateful to our today's speakers who answered our invitation and expressed their wish to share their knowledge and understanding on this topic. I wish us all success, so that today and tonight will be really interesting and fruitful. And now I want to introduce our guests and speakers, and I will start with Harold Wolf, President of HIMSS. Next speaker will be Mikhail Bakhtin, Deputy Nikiforov Center Director on Information Technologies, Vadim Zhuk from Pirogov Clinic, the founder of Adrenaline Net, and Catherine Pratner, Director on Sales of C-Systems Company, one of the largest system integrators from the Czech Republic, working in the system of healthcare. And now the floor is yours, Mr. Wolf.
Good afternoon. It is an honor to be here, and thank you so much for this incredible welcome and chance for my first of what I hope will be many visits to St. Petersburg. I have had a chance to be in Russia before, and I've always enjoyed my long-standing relationships, and it is an honor for HIMSS to be here with you today. I'm going to see if I can get here we go. I'd like to spend a few moments introducing you, for those that have not been very familiar with HIMSS, a little bit of our organization, and then we will talk about some of the key challenges in healthcare around the globe, as well as our focus on patient-centered care, which is truly the next frontier that we are now embarking. HIMSS is a global organization, and we are proud that we are in the midst of establishing our community here in Russia. And we have communities around the globe that are made up of individuals much like yourselves, who are thoughtful and dedicated to improving health through the use of information and technology. We began in 1961 with a group of computer scientists that began to use data and information to analyze healthcare and health delivery. And today we work in analytics, We work in Personal Connected Health Alliance, which works on standardization of devices, HealthBox, which works in both consulting and investments inside healthcare for innovation. Our Health 2.0, which also finds innovations around the globe, and a media department, which creates articles, editorials, and brings to the forefront information impacting care. We are, by legal definition, a nonprofit, which means that the money that HIMSS collects goes back into our member programs for both education and the development of maturity models and frameworks, which then allow systems like this magnificent hospital to use as a guideline in the development of its digital health platform. And our main objective is the transformation of health through the use of information and technology. We used to think of it as just IT, but last year split apart IT into information and technology. Because so much has been developed on the IT side, we now have an investment that is made. And it is the use of the information from our technical platforms which is transforming health. The technology will always be there, but it is critical for us to begin to use the information to improve care. Our vision is simplistic. It is to realize the full health potential of every human everywhere. But I'd like to unpack that. I'd like to explain that a little. We have an old expression in HIMSS where you have seen one hospital, you have seen one hospital. When you see one clinic, you have seen one clinic. Meaning that each hospital, each clinic is unique unto itself. Each city, each village is unique unto itself. So our objective is to recognize, to bring the best health possible to any person no matter where they are, realizing there will be differences, but that we can use digital health to improve and to deliver on that care. And to do that, we are reaching a point in the healthcare industry where we must lean forward into the reformation, the reforming of healthcare ecosystem. This hospital is an outstanding example where we are shedding paper, improving communications, reducing times for testing, and improving both quality and safety quickly and efficiently. HIMSS has about 79,000, a little over, probably over 80,000 after last week in Finland, of members around the globe that are committed to sharing best practices and working together for the development of improved care. And fundamentally, it starts with each person in this room and our member base who bring best practices forward. We look at them as the real influencer, the real members of our organization. And when we have policies, when we have challenges, when we have thoughts from governments that ask us, how do we think about security? How do we think about best practice? We actually turn to our members and create collective thought. From that, we have developed what are called maturity models like NRAM, which lists what is the best practice of digital health when we move forward in figuring out barcoding and the electronic direction of a hospital or its membership in terms of its relationship to patients. Beyond the members are those stakeholder hospitals that are influenced by each and one of the maturity models we bring forward. And then finally, we work with the governments. We work with the influencers in the private sectors, the finance areas, in order to develop policies to support digital health and its growth. All of this comes together through our chapters, which we are developing in our communities, like the one we are now establishing here. And we hope and look forward that each and every one of you will have a chance to be a part of HIMSS, to share your knowledge with others around the world and the incredible best practices that you've already brought forward and continue to develop, and that others around the world will have the chance to come and share their best practice with you. Because it is only when we have a chance, through workforce development, through continuing education, through the opportunities to share in events and participation, that we can share our innovations together. So we focus at HIMSS on these 5 basic strategies each and every day. One is to make sure that the member value, meaning what you experience and participate when you interface with us, is positive. We are doing the right thing, and we correct it each and every day to make it better for education, for white papers, for thought leadership, and those exchanges. The thought leadership across the entire ecosystem has had a profound influence, not just on NRAM, which is the electronic medical record maturity model, but also on outpatient MRAM, which looks to use the electronic record in outpatient settings so that data and information flows back in. We have an analytical maturity model, which looks to say what are best practices across the globe in the use of the information. And the continuous care maturity model ensures that the warm handoff from patient to physician and institution are done in a way across the electronic record to make sure that the ball is never dropped and that each person's record and information follows them wherever they go. There's also a digitally image maturity model, which is best practice of how to hold, store, and to think about digital images, which frankly cost a tremendous amount of money to store. And just this morning we were talking about a lab maturity model, which is coming in the horizon along with our current efforts, which is a digital health maturity model encompassing all of these pieces. The innovation offerings and support I mentioned earlier will continue to be a focus. And finally, our expansion internationally, and thus the map you saw earlier, and again, how excited we are to be here. In the end, today, over 776 million patients live and work and rely upon clinics and hospitals that utilize our maturity models, are involved in the thought leadership of HIMSS on a global effort. So we're very proud to have gone over 750 million people this year that we know we are influencing both in standards from everything from interoperability all the way through to reimbursement models. And it is, in fact, a worldwide effort. Our growth over the past few years in the Asia-Pacific region and in China in particular have been huge. And these are just in 6- and 7-stage hospitals like the one that has been achieved here in St. Petersburg. And I want to talk about this for a moment because in our conversations with Mikhail, it is important to note how hard it is to focus and to bring forward the achievements that have occurred and the incredible success story of the improvements in efficiency and safety and quality that came along with this achievement. It's not about reaching stage 6 just to reach stage 6. It's about the results of what happens when you get there from a guideline standpoint. And again, these guidelines are an offering to follow, but each person has to bring them within the capabilities of their own domain. So warm congratulations again. So let's shift for a few moments to the fundamental challenges of healthcare on a global basis. These are fundamentally the issues that each and every system is facing. We have amongst us, and I am a member, the silver tsunami. The old guys who are coming up pretty fast, who are part of the baby boomer generation. I was at the tail end, I promise. But reaching up and now saying we're going to be retiring in the next 10 years. And with that, dependent upon the healthcare systems that we live in. We plan on living longer. And because we live longer, we'll carry with us more disease burden than we have in the past. And we've also gotten much better as a system, as an ecosystem, in actually diagnosing those disease burdens. So we see more than we saw before, and our aging population will bring with it. Geographic displacement, another challenge, is not just an issue of city versus rural. Many people can live in a city but not have access to the same facilities of the same quality. So the outreach of geographic displacement becomes a challenge. Our funding models are being stressed because what is happening with the aging population are more dependents and fewer individuals to pay for it. And we now have a highly educated and demanding consumer, and we will talk about that in a moment, a lack of actionable information, and finally, growing staff shortages, which are impacting systems around the globe. The World Economic Forum notes that in the future job reports, the #1 trend driving healthcare is, as we talked about before, the aging population. And this shows you the percentage of the aging population against the basic world. Europe, North America, and even Africa is experiencing an uptick at this time because they have overcome so much of the AIDS epidemic, which kept them flat all the way through the early part of the 21st century. But the shortage of healthcare workers is growing. There will simply not be enough clinicians and nurses to continue to care for individuals in the way that we care for them today in what is known as an encounter-based paradigm. The shortage will grow by 2035 to almost 13 to 14 million shortages across the globe. So how we deliver care must change. And this personalized patient-centric care that my colleagues will be speaking about in response to the expanding population, those are the needs and the centers for care so needed. Now, a patient-centered care is what it sounds like. It starts with the thought of the person in the middle and recognizing that it is not just the patient to the doctor, it is not just the patient to the nurse, it is not just the patient to the social system, but it is all across from skilled nursing, hospitals, pharmacists, educators, physicians, of which there will be a huge shortage in primary care. It is also mental health. It is the outreach and the inreach. It is building a system thinking about the patient on the outside of the system back in, as opposed to where the patient themselves sits in just a hospital. That is the biggest change in healthcare today. They feel empowered. They look at their information and begin to see how they can use information differently than any other generation of patients before. And they look up in a cultural challenge that says, I want the healthcare system to bend to my needs. Everything I do in my life is bending to my needs through my phone, through my laptop, through the devices around me. Every institution. Why would healthcare be any different? So this concept of a user-centered design of information sharing, of self-assessment and feedback, interactive learning, all of the components of our society that we use each day through the mediums that we have are now squarely centered on the next generation of care delivery. Personalized care, though, fundamentally requires personalized information. And this is where it begins to get one of the more interesting challenges that exist in our next generation of care. This graph represents the direction we have of the medical model and where it is currently headed. We think often of population care as sort of the mass production of care, if you would, where one target is used to reach many. But in the road to personalization, it leads all the way up to genomics and an individual's pursuit of what will affect just them. And we, as a healthcare industry, as an ecosystem, are moving in that direction. But people are impatient. They are inventing their own system around them, and they are layering on top of ours a health model which is with their patients and their preferences and their personal circumstances. The number one doctor in the world today is Dr. Google. And so the challenge for each and every one of us is to bring together the health and the medical models towards a personalized health delivery that encompasses both the devices of the individual and the care of the facilities, and frankly, a shared knowledge management. Because what is happening here in the United States, which is the same in Europe, Russia, China, Australia, in all the developed lands, is that individuals are now walking into their doctor's office with predetermined explanations of their ailments, turning around and having already researched prescription drugs. 47% ask his or her physician to prescribe a specific drug or ask to discontinue something that they already are looking upon. They are asking for self-diagnosis, and 52% are offering their physician proposed treatment before the first encounter has even taken place. This is an exercise and a race in knowledge management that has to be shared through common personalized information. So our traditional base paradigm has to shift from one patient at a time, where you only know about the patient and you're the only one when you're in the office. Limited use of IT to what we have seen here in this facility, which is a robust patient record, data that is used and looked at on multiple levels, predictive modeling with clinical decision support, and a team-based approach that actually has the patient as a part of the care delivery team. Now, this slide I look upon as one of the most important, because whenever you go to implement, it is rarely about the technology. The technology only succeeds when you bring the people and the processes along with them. Technology is a fantastic enabler, but where are the physicians and the nurses? They have to buy in to the means of transforming the care system. It is about culture, and it is about the processes changing so that the system can take advantage of each and every one of these particular opportunities. So from an innovation standpoint, you can't do it incrementally. You literally have to think about it in more of a big bang. And this led me to this one slide and some closing thoughts before a question or two, which is to recognize that the electric light did not come from the continuous improvement of the candle. It came because we made a decision to illuminate in an entirely different way. And I would challenge our whole industry, I would challenge patient care to redefine our own illumination as to how health is delivered, rather than thinking we can get there in such a short period of time of economic challenge with just incremental improvements. So in the end, our vision is again to realize the full health potential of every person, to utilize the information and technology and bring it forward in a world of patient-centered care. Thank you.
Вопросы к Харальду? Harold, when I will ask you the question, could you tell me what is the HIMSS approach on connecting in-hospital care of patient and out-hospital care, in-house care? How it's possible connected and to find some benefits?
Yeah, that's a good question. You know, the blend that we talked about in the slide where the two, the medical model and the health model are coming together. One of the areas that is a passion of ours is interoperability. The data must talk to each other. And so whether you're using an HL7 FHIR platform, Continua, other data models that are guaranteeing interoperability, if we do not ensure the use of open source and the connectivity of the data, we will miss this opportunity to bring them together. So one is we are working hard on an international and global basis on interoperability standards. The second is actually forums just like this, to recognize that the patient themselves have an incredibly important seat at the table because they will race ahead without us. And we do have to recognize that our systems must be flexible outside in. And so the development of care and patient at home and the development of care that is delivered from the individual back into the system is as equally important as the system back to the individual.
Thank you.
You're more than welcome.
Какие-то еще вопросы?
Большое спасибо за доклад, замечательный. Хотелось бы знать ваше мнение в силу сказанного только что. Еще раз спасибо большое за доклад. Хотелось бы знать ваше мнение в силу сказанного того, что многие приоритет все-таки за пациентом. Но пациент, понимаете, он, конечно, будет идти вперед. Он будет совершенствовать свои общечеловеческие знания и прочее, прочее. Но мы в реальной практике порой сталкиваемся и с безответственным отношением пациентов, которые требуют к себе очень ответственного качества и которое надо как-то оценивать. Как вы относитесь к системам оценки качества? Кто это должен делать? Пациент, специалист или специалист и пациент, организаторы здравоохранения, политики, порой надзирающие органы. Вот что в мире по этому вопросу и какое ваше личное мнение?
I'll let you unpack that.
The question is, who should control the quality of treatment? The patient. Quality of treatment. The patient, the public authorities, doctors, politicians. What is your view on this?
On quality.
On quality, yeah, because patient himself sometimes is not able to follow the requirements, to be correct with his health.
Right. Complex question. First of all, I think the answer is it's literally all three. So it's all three is truly the answer. The physicians, clinicians have an accountability to understand the science that they bring forward in patient care. A patient has a mutual responsibility to participate and listen. A patient who does not engage in their own health works and puts the physician at a handicap. So, it's not fair to come in and say, cure me. I'll do nothing about it, but just go ahead and cure me, right? Social determinants, a person's action, what they eat, drink, exercise, how they stimulate their lives is as much a part of the delivery of health as it is of what a physician can do. In fact, it's more so. We know from studies that 40% of a person's health is determined by their own actions. So I think those two we understand. Where governments and policies come in is in two planes. First of all, each person wears multiple hats. They wear the hat of the citizen because they have expectations of what facilities are available to them, where their taxes have gone and what the state would provide. Secondly, they have the expectations of a patient because they do want to be cured and have something occur. And finally, they have those expectations of a consumer because they want it done yesterday, they want it done through their phone, and they'd much prefer just to take a magic pill and get it done. But nonetheless, those are their expectations. So the government has to help set policies and guidelines, standards on interoperability, expectations of how data will be shared, things of this nature which are critical to get the right information at the right time to the right clinician or patient to save their lives and give them that opportunity to participate.
Thank you.
Okay.
Thank you. Теперь я хотел бы...
I think we're all set?
Yes.
Okay.
Thank you very much.
Thank you all very much.
Thank you, Hannah. Я хочу пригласить следующего докладчика. Михаил Бахтин, помощник директора СП.ARM по медицинским информационным технологиям.
Уважаемые дамы и господа, позвольте вас приветствовать в нашем центре и поблагодарить всех и каждого за то, что смогли найти возможность посетить наш центр, за то, что вы интересуетесь информационными технологиями и то, что продвигаете информационные технологии в своих лечебных учреждениях. Но нам повезло, что в свой второй визит в Россию
His second visit to Russia, Mr. Wolf has found an opportunity after a very intensive week at European Congress to visit. He has found time to visit our clinic, and I hope that we can consider this conference to consider an external session, the same as in ice hockey when they play one of the games at another rink. And I really think that we will use all the benefits of his presence here and the presence of other European colleagues who will tell us how the most critical issues that worry all of us are being resolved all over the world. That's the main task of our conference. In order for you to better understand where you are located now and what we've managed to perform behind our fence, I will tell you more about our center, why we have come to HIMSS and what were the results of it. So, the history of our center started in 1997 when we opened our first clinic located in downtown St. Petersburg. This is a small clinic, 120 beds. mainly main field of activities is general practice and therapy. And one time past, we understood that we have to expand, develop high-tech methods. And so 20 kilometers from downtown St. Petersburg, a new surgical clinic was built. That's the center where we are located now. As of today, our network consists of 2 clinics and an outpatients department where 900 doctors and nurses are working on a daily basis, 530 beds. We have carried out 9,000 operations in 2018 and had 150 outpatients and 15,000 inpatients. So this is not the largest medical network that exists as of today, but it allows us to provide all types of medical care. Our experience of using medical information technologies dates back to 2001. Well, actually, in 1998, we finished our in-house development of the system because it is very difficult to make a good system separately in one clinic only. So we started searching for a good system. In 1997, we have chosen MedTrack from Austria. In 2001, we launched it and commissioned it. And in the course of 10 years, we worked with this very powerful international medical information system with full functionality. It acted as a textbook for us to facilitate our entrance into this field. In 2010, for the first time in this country, we have switched from this system to the Russian one, the first actually import substitution in Russia. And this new system allowed us to make a new step in terms of introducing IT technologies in our clinic. When you are moving along any way, the best thing is to understand which way you are moving to. The best way to do this is to go through the external audit or certification. We started choosing from various certification systems, and we found out that there are 3 of them. The most general and well-known is ISO, quality assessment of services provision. Its breadth allows to understand. You see the Chinese temple not far from Kuala Lumpur on this slide, and the certificate which shows that all the services in this temple are performed at a high quality level. ISO are really very broad standards. Hence, the most popular and very trendy as of today in the Russian Federation is GCI, or Joint Commission International, a set of rules, a set of methods that dictates how to provide medical services in a medical institution in a proper way, what the medical personnel has to know, what and how has to be labeled. And it's a very large, very broad work in terms of certification of the medical institution. But there is one nuance here. Visually, after you implement this system, unfortunately, you won't be able to see how these rules are being fulfilled on an everyday basis. And if they are not fulfilled on an everyday basis, if they are not updated, if one of the staff has left the work, the newcomers have not gone through the education, and they do not know that you have these rules, all this will lead to the collapse of the system. The system won't work, simply. That's why, and that's how we paid attention to the knowledge and philosophy that are promoted by HIMSS. And great thanks to Mr. Wolf, who told us about the philosophy, the spirit of HIMSS. Hence, I can save some time. But the main thing for us when choosing this system was that HIMSS proclaims the use of information technologies for the sake of providing safety of patients, quality of medical care, and management, cost management. And when we looked at the map of Europe, we've seen that there is some unfairness. Western Europe is involved into the process of certification. There are many hospitals that have undergone this certification and assessment, while Eastern Europe and Russia were left beyond. We decided to alleviate this situation, and there were several partners who joined us in this project. This was Sparm and InterSystems. So we moved along this way, the three of us. We thought that it would be a quick journey, but after the audit and questionnaire, we received a long list with the things that we had to mediate, and these were different discrepancies that we had to eliminate. In 2012, we started our dreams about how to go through certification, but we couldn't even apply at that time. But unfortunately, Russia at that time was not even part of the list of the countries who could apply. It took us around 4 years to finally knock at the door of the global HIMSS, and they've heard us. And we managed to tell them that 1/6 of the globe, that is very often a white spot on the map, is not only Arctic but also a huge country. And maybe we have to ask Mr. Hull why the Far East of Russia is allocated to the Asian region already. We're still one country, and we are included into the European region as one country. So it took us 4 years to manage to deliver this message that Russia exists and there are technologies working in Russia. In October 2016, the first inspection took place, and then 1.5 years it took us to perform our home task. We reported about all the work we have done, like in a quest. You open the doors, you pass through the hall, but there you find another doors, another hall, another doors, and this work was quite long. We've lost some of our personnel in the course of this quest, but we managed to reach the end, and in December 2017, we received an approval on compliance. What did we comply with? These are 7 levels or stages from 0 to 7 that the medical institution has to comply with. And you can't comply with the next stage until you comply with all the requirements of the previous stage. Each and every time you have to prove that after you've passed a certain stage, you can move forward. That's the game with its opening doors and passing the halls. Probably the main basis of HIMSS system. But we were opening these doors not in the course of the last year, 2018. We've been moving towards this from 2001. We were one of the first in this country who introduced the electronic lab system and EMR. We were one of the first who introduced the barcodes, and thus we eliminated the problems of handwriting of doctors, which is notorious for being undecipherable. We managed to we were one of the first to manage to receive the results from the lab tests directly to EMR. All the doctors started writing their protocols in the common space, and there was a possibility, hence, to read all these records without waiting for the paper medical record to be transferred from one office to the other. We have launched a common list of indications for the patients, and thus we've managed to see all the indications for the patients, and in the real-time mode how these indications are executed. Thus, we had an opportunity to introduce changes and amendments into the medical process, not one day prior to discharge of the patient, but at the moment of medical care provision or non-provision, maybe a non-execution of some services. because we see all this in real-time mode. We have mastered the flow of medicines from the main warehouse and suppliers to the pharmacy and then to the ward and to the patient. Thus, we've managed to be able to see how many packages of what medicines are delayed at what stage. This system allowed us to minimize the stocks in the wards. On the other hand, to maximally satisfy the medical doctors with the provision of those medicines they needed. Without the electronic system, it would have been difficult because we could never guess where and which medicines could be delayed. Because very often medical nurses would stock 2 months or even more stocks, and that was absolutely right because they knew that some of the supplies could be delayed. But this is not right from the point of view of the proper use of these medicines, because these medicines may be needed by other wards. We made our system more complicated. We managed now to define the place, the time, with us were able to learn what was being performed and where and how, which resource was being used and where. In our old clinic, we modernized the radial diagnostics equipment and transformed it into the digital one. In order to have digital imaging, we use this experience in this new clinic, and in this clinic we do not use any films. All the imaging is digitalized, and everything is being accumulated in the common archive. Each medical doctor may have any image, any scan he wishes immediately. We have the special DICOM server, and as identifiers, we use the full name of the patient, but also the idea of the test. And thus, the imaging specialists do not have to think about how to register the patient. They immediately see the indication and the patient's name. And finally, we have come to the problems on the basis of which we didn't comply with stage 6. When we were introducing the system, we allowed the medical doctors to enter their entries as was more convenient to them, and different doctors use different formats. But when time passed, we understood that we have to have highly structured entries, and we have restructured all our protocols, and thus received the possibility to use the information that is being entered into the system in the decision-making system. For example, the risk of deep vein thrombosis was changed due to this protocol of risk assessment to the result of bringing down the number of complications in the clinic. We also managed to involve the medical nurses into the risk assessments, and thus we may start preventive measures in those patients who have the high risk of development of complications or maybe bed sores much earlier. We have changed our system of medicines indication by adding external database. After the indication is being made, our external expert system checks the drug-to-drug interaction, and in the result, the external system would tip the doctor in case of any conflict between the newly prescribed drug with the drugs that the patient already takes, or the diagnosis and diseases the patient may have. At the end, we have introduced a closed-loop medicines administration system that allows us to see the movement of medicines from supplier to the warehouse and check that the patient receives the medicines, exactly those that were prescribed by the doctors. The nurse uses the special pill container, sticks to it the barcode of the patient, and with the use of this system she can check against the barcode. Every time when she puts pills into the container, she shows the system the medicines she has put into the container for specific patient, and the system controls whether everything is right. The patient has a bracelet, and the number on the bracelet of the patient and the number on the medicines container have to correspond. Thus, we are sure that the patient receives exactly the medicines that were prescribed to him or her by the medical doctor. All this together allowed us to be certified in accordance with HIMSS Stage 6 and put a new star on the map of Europe and enter this large family of certified hospitals. Is it a lot or not? It is we are the only clinic in Russia that is certified, which is exactly the same situation as in Denmark, which is considered to be a very advanced country in the sphere of healthcare. We have modernized all the diagnostics equipment in our clinic, and we have now opportunities to see the ECG immediately from the ARM, the results of ECG. In the medical system, in our medical system, we actually created a black box that is being registered, registers all the data on board of the aircraft. We do the same with our patients and medical services. It was a great surprise to us when we digitalized all the entries. It turned out that if you got rid of paper, you have to be ready to produce the electronic entries to the patient, not only at the office. And we understood that we have to introduce the Wi-Fi, distribute tablets among the medical doctors so that the doctors would be able to show the patients these medical records. Or, for example, the anesthesiologists to read the protocols of anesthesia in the operational theater. We also receive a lot of analytics from our system. For example, this pie diagram. We ask from where the patients have come to us, where they heard from us. Either their families told them, either other doctors or the medical insurance company. Some patients find us on the internet. Thus, we managed to restructure our whole advertising and marketing activities. And we now invest much better and save money on things that are not really necessary.
We now can plan which medications to prioritize and which drug intake we should monitor less. We now know the tools for that. We have the apps that send patient data from the patient's home to the doctor's workplace. This has allowed us to introduce information service and technology in every medical department. We can now manage quality of the medical assistance and ensure the safety of the patient. Altogether, this has allowed us to optimize medical care provision and be in tune with the current developments. Any questions to Mikhail?
Здравствуйте, меня зовут Артем Остапов, я руковожу
Hello, I'm Artyom Ostapov. I work at DocPlus, we're the first Russian online hospital, and I'm there responsible for the digital technology. We use AI-supported digital medical protocol analysis, which can now decipher 100% of all the medical patient profiles that we receive in the form of text. How do you work in this field? Well, since we have to handle a lot of information, therefore the first step for us was to get access to medical files at any moment and from any location. And now the head doctor of the Nikiforov Center can read any medical protocol from his office at any moment. We have an expert group also who checks manually these protocols. They read them. The technology that you have is arguably more advanced, and we have been introducing parts of automated analytics so that we can pick the records that will have to be checked by people. Therefore, this is in a way a fully immersive automated control, which is in the most challenging situations facilitated by human intelligence. Artificial intelligence really needs huge data in order to set it up right, and we not necessarily always have that for every situation. Thank you, Mikhail. So I hope that more questions will be asked during the Q&A session later on. And as for now, thank you very much, Mikhail. Let's move on with the program. And I would like to invite Mr. Vadim Zhuk, a deputy head doctor at Pirogov Clinic. Okay, so you stand by and remind me of the time, okay? Today we discussed quality already at great length, and it means that this impacts the healthcare system in general. And my presentation also deals that. Where do we want to go as healthcare managers, and what are the healthcare facilities and qualities that we want to receive as patients? And safety now is something very important and meaningful to all of us. Very simple elements can now be evaluated from the point of safety. Remember the Samsung phones when they started to blow up, you know, and luckily the company were able to track it down. 90 years ago, to take a flight was a lottery, and now you have more chances to die from the bite of a bee than in an aircraft crash. Therefore, when we discuss damage management, risk management, and so on, the chance to be harmed in flight is 1 out of 1 million. And in healthcare system, 1 out of 300 patients gets a negative result when they deal with the healthcare system. This, I think, is something you're aware of. This is statistics from the United States. They, I think, quite honest in collecting this data. And now medical errors rank 3rd in death reasons, following heart disease and cancer, and coming before accidents and respiratory diseases. It's about 9.5%. This is official statistics in the United States, but I believe this reaches out from national healthcare system. WHO believes that every 10th patient in developed countries is now receiving harm in a medical situation. This can be misdiagnostics, bad surgery, wrong surgery, wrong prescription, and so on. This all is happening place in Russia. We don't have this kind of statistics, and therefore we can only quote some professional statements. The National Medical Therapists Congress have voiced their belief that every third diagnosis is erroneous, and medical errors in 80 to 85% of the cases can lead to complications that can be fatal. Therefore, safety has received a lot of attention from WHO, and in 2002, the resolution of the WHO member countries was phrased as follows, that every healthcare system must ensure patient safety as a fundamental operational principle for every system. Salus ergoti suprema lex. This is one of the first Latin phrases the doctor learns, and best practices of quality management in healthcare are built around this phrase, around the needs of the patients, be that myoclinic and so on. We could also perhaps rephrase it to mean safety as a prime priority for not just patients, but also for medical institutions. This is also, safety is also profitable, because by bad quality we generate losses. In Russia, bad practices lead up to $30 billion that need not be spent if the proper quality was ensured. Quality and safety are connected very directly. If the quality is not there, then the service is not provided the way it should be. Say 10 years ago, this image, this call to ensure quality and safety in 100% of the cases sounded utopian, but now I think we are on the way towards it. Perhaps automated and robotized systems will be able to achieve that, but so far we're taking some steps towards it. And one of these steps is, of course, a standard. Don't we lose the patient if we introduce yet another standard? No, because we will put the patients in the center of this system, where a standard at every interface where the patient has to deal with a medical institution. The standard is based on an existing system of management that is constantly updated. Second principle is that quality can be managed in a number of ways, because if you think you manage it the right way, you may not be aware of the alternatives that there are. And the third principle is that once the organization changes, the quality management system must be updated. Sometimes you don't see it because you're too small, that you don't have a person who's responsible for that. But what we do for the National Healthcare Development Program, which wants by 2020 to introduce quality management systems in 95% of all medical institutions, while quality management is always there, so we are already somewhere vis-à-vis this figure, but I think this can be achieved, and of course those who are actively pursuing that would benefit the most. Based on the government's decision from 2014, number 294, it's been supported by Rospotrebnadzor, they've suggested that we need not invent a new quality management system. Here we list both international and national quality management system coming from Australia, Canada, and so on. ISO is, of course, a standard which is very well known, and thanks to this standard, when you buy a bike in Russia, you can buy parts for the bike coming from Brazil. And this standard was originally based for manufacturing. It didn't necessarily was created to service healthcare or other services. The most recent version, they seem to cover now services as well, but let's see what they do there. If you ask Yandex, this is a Russian national search engine, then what you end up with when you try to find St. Petersburg and ISO, and there you will see this advertisement that would suggest that you implement ISO quality management standards in a day, 2 days, or 3 hours. And this is, of course, impossible, but that's what we see now. This is what the market offers. JCI is a standard that came around in the year 2000. This envisages that the highest level of operational culture is there among the employees already before it's introduced, and one of the key demands of the JCI standard is that all of the institution's employees must understand and use in their work all the key principles of quality management. Therefore, such a system is rather large, it's hard to deploy, and very cost ineffective, because you will have to train and administer a lot, because this covers patient safety, drug movement, information movement, and so on. All of this will have to be prepared from the point of view of information technology. If you look at how many of these there are, then it's a whole ecosystem that will have to be changed and updated. This is a good illustration, because there is the road safety regulations, which are mandatory for everyone, and this can still result traffic situations that look like this. How do we regulate this now? We recruit more and more policemen, give them more cars, give them more resources, and so on. Although this could have been regulated by creating different infrastructure which will remove the threat of a complete fallout. And the Royal College of Surgeons, Professor Dr. Salman, said that I need a technology which will make me do the right thing in a much easier way, and which will prevent me from doing the wrong thing. What does it mean? It means that there must be a safe environment, a safe ecosystem in the hospital, which will ensure both the satisfaction of the patient and provide the highest quality of all the services, as well as their safety. HIMSS, of course, when it came around in 1961, was called something else. It was HMSS. There was no I in there, and it grew year on year. And around that time, one of the programming languages, which EPIC-Cerner, which is actually used in QMS and other such systems, came around that time. And then they added I, because that was reflective of the key change in the environment. If you follow HIMSS standards, you must first and not overuse and do not need too many resources. You have to be patient-centered. You can always find things to humanize and to digitize in any medical organization. And HIMSS is there to find things that you can make more humane. Because if you introduce a HIMSS-based standards, things will become smoother, your experiences will become nicer, and you'll have to follow it step by step. You cannot move to stage 7 before you've implemented stages 0 to 6, and they ensure that the environment is created. We are hosted today by Nikiforov Center. They were the first to introduce HIMSS in Russia, and the technology that they borrowed from Sparm based on QMS information management system, and everyone has seen the certificate. They've achieved that. This is fantastic. But without QMS, I don't think this was possible. Because in my opinion, QMS, I've used it for 10 years already personally, and it has become much more than a medical information system. This is now a reliable, safe, adaptive system. Of course, it can fit any medical situation, but it's evergreen, it's ever-changing. I spent 10 years, as I said, and it continues to grow. And in this illustration, you see the green leaves covering all of the building. I really like this idea. And when we were looking for these gaps, which are not covered or supported with our system, when then the user would make a request to the vendor, they have some resistance, but they always can help you in order to bring up the standard to the 6th level quality. So what does it mean to reach level 6? In the United States, I think, and this is all statistics, about 27% of all the medical institutions are ranked level 6, and a lot less than level 7. In Europe, it's not much better. If you look, it's 125 institutions. It means that in Europe, 41 have received level 6 out of 2,500 applications, and only 9 are certified level 7. I do recommend these books by Jim Collins, From Good to Great. He discusses here institutional breakthroughs and the conditions for them. And I really believe that this level 7 would be the next breakthrough for you. Today, it's not the most expensive to actually buy and own an information management system. It's much more expensive to not have one. I'm sure that you share this viewpoint, otherwise you wouldn't be here. It's much easier to follow the leader. We have a leader, we're ready to follow, and I believe that the leader sees the blue sky ahead of them. With that, thanks very much. Thank you for the presentation. Any questions to the speaker? No questions so far. Thank you.
Я приглашаю следующего.
Good afternoon. Healthcare is difficult, most of you know, and especially in this hospital of friends like Michael, I feel myself a little bit preaching for the convinced already. Most of you have got experience how much energy it takes to get into the future of healthcare, because too often we do not accept advice from our best friends to change the square wheels into round wheels. Ladies and gentlemen, my name is Johan Beun, and I try to share with you some experiences about quality and transparency. AdrenalNet in the Netherlands was founded some 4 or 5 years ago, and it was a cooperation of 6 academic hospitals where we wanted to have better information and better care. And we did it with the Royal Society of Medical Specialists, in this case the endocrinologists, nurses and other doctors' unions were involved, including 2 patients' organizations. And after 4 years, we are the single source of reliable information in the Netherlands for all hospitals that still treat adrenal diseases, for doctors, nurses and patients. And we are also in a situation where adrenal patients do not visit anymore all hospitals. We have come in a time and age where we need to specialize, where we need to make choices. So don't expect in every hospital to be treated for all diseases. In Europe, we have come to the agreement that we want to have European reference networks, ERNs, and that for certain diseases we want to have only specialized diseases. And don't think that I am telling the doctors what specialized diseases should be, but it's the doctors who decide themselves. We only help them. What was crucial for our organization was not to repeat everything that had been done. And what was very crucial for us, that we needed the voice of the doctors, the nurses and the patients to see what they wanted. So we started with a baseline measurement in the Netherlands, and we asked them, what do you want? What is proper care into your eyes? What is proper care? How do you define proper care? Help us to write it down. And we consulted hundreds of nurses, medical specialists, pharmacists, and also in countries around us. Ladies and gentlemen, healthcare is very complex. Albert Einstein taught us that we cannot solve our problems with the same thinking we used to create them. So looking to myself, it's about time we need to move. It's time to facilitate a new generation. On this photo, you see the niece of Johan, and the little boy in the middle is my grandson, and he's taking over my tools, and that's how it should be. But it requires early training. Don't forget to train the next generation and spend a lot of money in it. Our objectives are to have an earlier and better diagnosis, because for rare diseases it's frequently that the diagnosis is between 3 and 13 years. We want to have better care in emergency situations. People with, for instance, an adrenal crisis have got a golden hour. When you give them enough hydrocortisone in that moment, no problem. You have a window of opportunity for about a day. If you forget that, then you have a window of opportunity for the rest of your life because they're dead. So many triage systems in emergency wards don't fit. That is one of the things that we had to change. And we also wanted to have better quality, specialized for chronic disorders. We want to have co-management, and co-management is easy said, but difficult to produce. And we wanted to have quality standards, and I will come back on that on quality standards, because a quality standard is not an easy thing to create. So at the end of the day, we wanted to have maximum transparency, and we needed to have a lot of reliable data from all parties concerned. Therefore, we needed to discuss with the people semantic interoperability. 3 old guys like this can be a different and a dangerous story. If they don't listen to each other, and when it's not semantic, one says it's windy today, and the other says, no, it's Thursday, and the third one says, let's have a beer. This is more or less frequently the standard modus operandi in healthcare, because we don't use the same standards and we think we understand each other. Well, this is a very friendly picture, of course, and yes, there is communication going, but it's not interoperable. In essence, it is dangerous because it's not semantic interoperable. And we need to talk about it, because quality standards, one of them is that we fully understand each other. And we work on a special field of semantic interoperability. ICD-10, LOINC, and SNOMED, etc. are crucial for that, to make sure that all electronic medical records are equivalent and can communicate with each other. And we strongly advise that we learn from each other. Electronic medical records adoption models, the so-called SPARM, are well known here. HIMSS is well known here. Joint Commission is well known here. ISO also helped us to start. But it needs to go further, and it needs to go to other hospitals, not only outside St. Petersburg, but in the global world. We need to talk to everyone and every doctor, nurse and patient that we want to have quality in care. And quality in care is not only an obligation of the government, it's your and my obligation. We need to define what is quality. Because if we do not care about this quality, we have a problem. And it starts to make the right wording and to make semantic interoperable. What we did, we created information that ICD-10, SNOMED, and other qualification systems could be exchanged to each other. They are mapped. And also in your country, please consider to use SNOMED. SNOMED for many universities are free of charge and start with a free license. We needed to educate the world. We need to educate especially the IT companies, because a hospital, healthcare doesn't need new toys. We needed solutions. We needed to discuss with the doctors and the medical specialists to understand and to accept that they are team workers. Because healthcare is a system of co-workers, and it's a greater process for sharing care. Sharing, sharing, sharing is a permanent attention for all of you. So if your handwriting is lousy, improve it or use a system to it. Always consider that what you say and what you write and what you communicate is to be meant to be used second or third time by other people who were not there on that meeting. Because the great problem with a patient is he has got two ears. One is to accept the information from you, and the other one to leave 90% out before he's out the hospital. So the net result is maximum 10% that he can re-understand. And please make sure that he can share your information also at home. More and more in the Netherlands and in other areas, we need nurses to help us, because we have a shortage of doctors. We have an explosion of what Hal called the Great Tsunami. In the old days, many people would have been dead already. I myself are nearly 68 years, and I'm still working, which is quite normal now. My grandfather died before he was 50. So we have people living longer, but consequently having also more complex diseases. So although people like myself were not educated to have a complex disease when we were young, we're getting it. Now we need to be educated, and we need therefore the nurses. So please respect the nurses as being a crucial element in your future. And of course, educate the patient, because there's nothing such like a free lunch. Uneducated patients are lousy patients and are not good for your nor their future career. If you want to grow and to be the most excellent hospital in Russia, which you are already maybe, it also requires educated patients. We need to change. All of you know that the business model is expensive and soon too expensive. Even those who live in the rich part of the world cannot afford any more healthcare. In my country, it's about 13.8% of our gross national income. We just haven't got enough money anymore to pay for it. And The problem is that we workers in healthcare need to do it, because our governments, forgive me to say, frequently do not have a vision. Our governments too often run behind the reality. It's us that needs to share the vision and needs to give the vision, for instance, to the doctors, nurses, patients, and to the government, and that we start thinking about hospitals, that they are different. In the old days, hospitals were beds and bricks, very easy. But today, a hospital is a care-producing institute, sharing, and most of the patients are outpatients. So more beds is no fun, is stupid. More information is fun and gives you the future. But the problem is you need to share it. And what is very important, more and more, you need to accept information from the patient. And you need to talk with them sooner or later to accept all that information, that these data will become valuable information for the healthcare process. And, ladies and gentlemen, obvious that healthcare, social welfare, and care for seniors like me are not three different processes. It's one process. We need to adapt the mentality. And later on, thank God, Oleg Medvedev, my dear friend, will tell you what kind of beautiful tools there are these days to improve it. But yesterday's answers are not good enough anymore to continue in the future. I told you, please stop investing in bricks. Invest in people and knowledge. Mind you that the cheapest answers are not always the best. On this moment, we have a serious debate in the Netherlands for continuous glucose monitoring, where we have these pads on the arm, and where it's proven that about 75 to 77% of the people are much better off. And the stupid insurances are not prepared to pay for it. And so it has come into Parliament, and soon, one of the first times that Parliament will introduce a new law that these things also need to be available in healthcare. And please understand that if you are thinking that you are too small to make a difference, you have never been in a tent in Africa with a mosquito on your own, because this little mosquito made that I didn't sleep all night. Quality standards for adrenal diseases are not a national situation, but are a European situation where you have national editions. This is the Dutch edition. We worked on it for 3 years with 2 doctors, and now it is a part of the Dutch and the European legislation. So if there is any dispute between a nurse and a patient, between a doctor and a patient, or between doctors, this is the only reference they go to. We do for e-learning on nurses, and we have in the last 2 years 120 nurses educated and trained in adrenal diseases. We make guidelines for hydrocortisone to prevent Addison crisis, and it has been now translated into English, Danish, Icelandic, Norwegian, Swedish, German, and Spanish, and maybe sooner or later in your language as well. And an app, of course, is available in many languages. But the very crucial thing there is that if you're using an app, you need to make sure that the patient is educated to use it, but that the app also will produce information. In the old days, a patient came to the doctor and saw the doctor for 10 minutes, and that was it. Now, that we will prepare a diary there, and the patient will need to send in the results 24 hours before he sees the doctor. So you have a much better information as a doctor, and your starting position to make it into a success is much better. But you need to be able to receive data. And last, ladies and gentlemen, adherence in medical problems is a serious thing. We came to the conclusion that too many pills are all white. And we expect people to take 4 times a day different milligrams of hydrocortisone. And we came to the small but easy solution. Nobody dictated us, only a few patients. He said, please give me different colors. Then I know what the different weight of the tablets are. So now we are producing different type of colors for a pharmaceutical organization, and we also did it in a weak blistered strip. And it was a piece of cake, but we never thought about it. It was the patient that helped us. I thank you very much for your time. I highly appreciate to be here. I think you have a marvelous hospital. Michael and his colleagues have done what I would call a miracle in the last 24 years. I have been present only 15 years of that. And I wish you good luck for the next 15 years. I will not be there because by that time, well, my hair is too gray. But I thank you very much for your attention.
Вопросы? Johan, then I have a question. You mentioned SNOMED several times, but in Russian healthcare facilities, SNOMED is not so popular. What do you think could be the challenges in case of implementing SNOMED methodology and standards in Russian facilities?
Well, to my opinion, SNOMED is not an obligation, but it's a unique opportunity. And I would strongly recommend to those of you who are in semantic interoperability to see what SNOMED can deliver to you. SNOMED on this moment is a cooperative organization for 52 countries in the world. And if you want to serve your citizen traveling around the world, and if they would have a minimum data set or a patient summary using SNOMED code, you would sincerely help them. And for most academic hospitals, it wouldn't cost you a penny because it's free of charge. And for those who have got commercial interest, you have to pay your fee. But I think your patients will be very happy. My suggestion is investigate it and then decide, please.
Thank you, Johan. Thank you. И наш последний докладчик в рамках этой сессии – Катарина Пратнер, директор по продажам компании C-Systems.
We are very pleased to be here today as an InterSystems and SP.ARM partner and share with you a bit of our experiences with healthcare on Czech market. So let me start quickly with some facts and figures. I'm representing company C-System. We are a top Czech IT vendor with turnover over 70 million euros per year and more than 400 employees. We are actually offering a complex ICT portfolio mainly for large companies and public sector. As each company, when it reaches its top, we started to look for new segments. And we've decided 10 years to establish a division of healthcare and focus on e-health. C-System became InterSystems integration partner, and I'm very happy that 2 years ago we've decided to spread our portfolio of hospital information system, and we became SP.ARM implementation and localization partner. So from our running integration projects, I can mention University Hospital in Brno, University Hospital in Olomouc, and Liberec County. So let me just mention two main activities we support, international activities we support. First, of course, and it's quite clear, it's HIMSS. And we are very, very proud to see SP.ARM as a certified MRAM consultant for HIMSS Europe. And the next activity is IHE. And my colleague Jan Hlavačík will tell you a little bit more about this activity later. Let me start with a question. How many different applications from different vendors covering clinical processes do you think is running in the middle-sized hospital in Czech Republic? Looking at Mikhail Bachtin, he will answer 1, definitely. Maybe some of you. I saw 10, okay. You are not from Russia, are you? I know that your experiences, at least from the Russian audience, will be 1, 2, 3 applications. In Czech healthcare, it's in mid-sized hospital at about 15. In the universities hospitals, we face the situation of from 30 to 50 different applications covering just clinical processes on different databases, different technologies. Each of these databases is keeping a patient data separately. So when we decided to achieve the healthcare market 9 years ago, we've been facing a situation which still persists on the market today. Just to keep it easy, I chose only few main applications. Hospital information system, you can see laboratory system, pharmacy system. I would like to show you, but if I turn, you won't hear me. So radiology system, PEC system, and down you can see also some economical agendas as a ERP, facility management, HR. That's also some applications sometimes you need to share the data with. And on the left side of the picture, you see some national registers, which we have to report some data. That's mainly Institute of Health Track Control, Institute of Health Information and Statistics, and Social Security Administration. So on the picture, you can see that our hospitals moved forward a little bit in the past because there was a need to share the data. The nurse doesn't want to always run through the hospital with the laboratory requests, wait for the lab assistant to bring the results. So there was need of some interfaces. But we ended with a situation that we have lots of proprietary interfaces from hospital information systems. Sometimes it's 20 different interfaces. There is not much of them well documented, some of them not at all. And you would not find even one simple person in the facility who actually has overview of the whole environment. So the main actually effect for the clinicians is there is not one simple place you can access all the data that are connected to one patient. And again a question. What would you guess is the approximate MRAM level of the Czech hospitals? We are standing here in Nikiforov Center, which reached the MRAM 6. In Czech, it's 0.8 to 1.3. We are keeping the second position in electronization of healthcare in European Union, but from the bottom. Not very nice, not very positive situation. But the world is changing and the hospitals are changing with that. There's a huge development in Czech Republic of e-government. Last year there was implemented electronic prescription. Next year there is going to be nationwide implemented electronic sick leave. We are discussing digital services for the patients. So it's necessary to extend the interfaces to fulfill all new activities and regulations. How the picture will look now. I think none of you want to be the IT department in those hospitals. And maybe some of you heard about the regulations regarding security in European Union, GDPR. How do you want to keep this mess secure? How do you want to secure the patient data? As my colleague Jan Hlaváček says, it's a time to fire the IT department and hire Italian chef, because that's mainly maybe the only guy who can make something nice and tasty from this mess and this amount of spaghetti. So, that was the question. So what we did, 9 years ago, we actually built in the middle of the applications integration platform based on InterSystems technologies. And not only this, we connected the applications. We try to use all the standards like HR7, DICOM, but it's not possible. We are using web services. I will only show you, or maybe not. Okay, on the right-hand side of the picture. We didn't want to be only the implementer of the technology. So to bring more added value to the customer and to actually manage more effectively the data, we developed our own applications and functionalities as a master patient index, as a document registry, central code lists. I don't know what is your experience in Russia, but in Czech, the code list of diagnosis is changing 10 times a year. So the IT development has to go and download the upgrade to each clinical application separately. Excuse me, I will steal water from Wolf. Thank you for your patience. So another functionality what we actually developed is identity management, where we manage all the user accounts and permissions. This part of applications we call C-System eHealth Suite. Mr. Kretchetov would not like to hear this. And the main benefit for the clinicians what we developed is a web applications.
It's best for photography.
Oh, thank you. I can make an advertisement for the water producer. On the top, you actually see a clinical portal. What is a web application from which, from the mobile solutions or mobile devices, each doctor can access all the patient data from one simple place. So, after 9 years of evangelization, when IHE integration was a swear word, also the Czech Ministry of Health woke up and started taking some steps. So in 2017, they introduced National eHealth Strategy, based on which they prepared methodological guideline for exchanging of the medical records, where is already mentioned and recommended IHE profiles as a standard. But this is still all theory. To actually implement even beautiful theory, you need money. And us, lucky us, and thanks to European Union, last year there was allocated 120 million euros for the eHealth projects, allocated for the eHealth facilities. So now, I didn't make a mistake and didn't jump to the previous slide. This is actually the architectural scheme according to Ministry of Health, as it was introduced in the methodological guideline. So after 10 years, it actually proves that our vision was right. And I believe that also our next steps and decisions will go in the right direction. But what is new on this picture, if you look at the left side, is actually the communication with the external world, exchanging data with the different medical facilities, also cross-country data changing. On the top of it, you see portal patient or patient portal. It's actually the layer to communicate and share the data with the patient, give them access to their electronic documentation. So the place for IHE profiles, we see exactly on this extended area. And now if there is not going to be any questions, that's actually a place for my colleague Jan Hlaváček to tell you a little bit more about IHE activity.
So, good afternoon, ladies and gentlemen. Thank Katarzyna for introduction and for, I think, to our friends from SP.ARM for invitation to here. As you saw, we really need some solution how to improve in standardization in data exchange, in data interoperability. So that's the reason why we became active, and we are proud to be one of the founders of IHE in Czech Republic. IHE was Czech entity of IHE has been founded in May this year. So it's quite new, and it was approved in April on Connectathon in Rennes. It was approved by IHE International Board. We are very glad that this activity is widely supported by Czech Ministry of Healthcare. So, what is IHE about? IHE is an initiative which brings together IT vendors and healthcare providers with the goal or aim to improve data exchange and standardization among hospital or healthcare information system. Also, in many cases, these activities are supported by public institutions, as we can, as I mentioned it before. How is it working? The building block of IHE framework is a IHE profile. IHE profile is a specification which describes how to solve a specific solution, specific interoperability issue. It defines, it specifies or recommends data standards which has to be used, and it defines set of transactions which has to be done to achieve successful results. And these, for example, how to deliver results from labs to clinicians, or how to connect ICU devices with your clinical information system. What is very nice outcome of IHE idea are also integration statements. They are a result of so-called connectathons, where vendors of IT solution implementing IHE profiles can check their solution together with a partner with the opposite side of the communication, and they can prove it and check that communication is working in the right way. The result of the successful improvement is an integration statement, and this is very successful document, especially for healthcare provider, when he can really rely that the solution which it would like to obtain will be compatible with the other solutions which are in place or should be part of the delivery as well. We in the Czech Republic deal with a lot of vendor lock-ins, where it's very difficult to get in touch with other, or to establish interoperability with other system, with the already installed system. So we see IHE as a perfect solution how to get over this a big issue. One nice experience from the Western Europe. We know the information that it already happened in Western Europe, where there is a hospital releasing tender for new hospital information system, and definition of the tender was done by only list of IHE profile which should be supported. So, and it was a complete specification. So IHE profiles are divided into so-called domains. What you can see here is that there are, of course, domains which relate to specific categories of healthcare, and also you can find domains like IT infrastructure, which cover profiles which are more, let's say, technical ones, like there is a special profile for consistent time, which ensure that all data you have among your system are using the right timestamps, or there is a special profile for transaction logging or for protocolizing accesses to the system. So why we need IHE in the Czech Republic? Of course, because that we really need to increase our IT development of our hospital or medical facilities. So then we are sure that IHE really can help with that. The other reasons are that there is a EU interoperability project in place, and these interoperability projects are based on IHE infrastructure or IHE profiles as well. There is also a recommendation of European Union to countries and healthcare providers to support list of 27 IHE profiles. And also we are in front of defining nationwide e-health infrastructure in our country, and we hope that this infrastructure will be based on international experience, so it will be based on IHE as well. We see IHE very interrelated with the HIMSS activities, because what we see is that once we would like to implement a specific level of MRAM, then we need increased interoperability, then we need exchange data. When we would like to implement IHE profile, which could help to exchange data, then we learn that we are weak on processes in hospital, they are weak on how data are structured, then this is something that has to be improved as well, and this is something what MRAM helps. So maybe they are not twins, maybe IHE is more or less son or daughter of HIMSS, because HIMSS, as I know, is one of the founder of IHE activity. Here you can see list of international-wide projects which are already running on based on IHE. So this is for us another reason why to support it. So, and at the end, 2 questions which I would like to let open, maybe for discussion, whether we will have a nationwide e-health infrastructure based on IHE. And another question is when the first Czech hospital will achieve the MRAM 6 stage as this beautiful hospital has. So, thank you very much.
Thank you, Jan. Вопросы к Яну? Then I will ask you. Yeah, of course. How?
Can you talk about the relationship between IHE and how it would interface with HL7 Fire as an example? Are they complementary to each other?
As far as I know, I saw that there are plans how to implement a Fire inside of IHE, because for some use cases the Fire is more efficient. So that's.
So they work well together.
Yeah.
Great. Thank you.
Еще вопросы? I think it's a question to both Katerina and Jan. You mentioned that you have partnership with SP.ARM, and my question is how Czech healthcare can benefit from Russian healthcare solutions.
Sorry, not that I don't believe that Honza will answer in the right way, but...
In this case, the answer will be nicer, at least.
Thank you. As I was showing you actually the scheme of the integration and told you about our experience with integrating the applications, we actually hit a lot of boundaries during this work. If you actually want to integrate a little bit more sophisticated, not only on the data level, if you want to move to the process level, you need process-oriented applications in the hospital. But unfortunately, in Czech Republic, there now not even one hospital information system which has implemented processes. So we know if we want to really answer all the challenges of the interoperability, and we want to process on the more sophisticated way, implement IHE profiles, which are very much also about workflow. It's not only about the data integration. We need a system which, first of all, has processes implemented, and second of all, has structured healthcare documentation. Because most of the Czech hospitals, they believe they have electronic healthcare documentation because they have PDFs. I think, yeah, thank you. The guys are laughing, because I think that's not only a mistake of our doctors and our management of the hospitals. It's too far from electronic documentation. So if you want to make analysis, if you want to share, exchange data, if you want to use it for scientific usage or whatever else, you really need to have a structured documentation. And if you want to integrate processes, you need process-oriented system. And this is what everything is included in QMS. And that's why we believe this is the most added value what we can bring to the Czech market with this Russian solution.
Thank you. Thank you a lot.